type A positive. It looks ordinary until an ambulance door opens. Inside, a patient is losing blood. The laboratory has identified the type, A positive. The blood bank checks its shelves and 4 different bags can move. A positive, A negative, O positive, O negative. 4 doors open toward one patient. That flexibility can buy doctors time when the shelf is thin. But now the patient recovers and returns months later to donate. The arrows reverse. 2 of those 4 doors slam shut. So how can one of the most common blood types on Earth receive through 4 doors, give red cells through only 2, and still be one of the hospital's workhorses? The answer begins with 2 tiny badges. Picture every red blood cell approaching a security checkpoint. An A-positive cell wears an A badge and a second badge called RHD, the badge behind the word positive. Scientists call these badges antigens. That simply means surface markers your immune system can recognize. Security sees a familiar badge and waves the cell through. But an unfamiliar badge can trigger an attack. That is why our patient could receive A-positive and A-negative cells. Both carry the familiar A identity. O-positive and O-negative also passed because O-red cells arrive without an A or B badge. There is less for the patient's security to argue with. And because the patient is already Rh positive, either positive or negative red cells can usually pass that second checkpoint. 2 ABO choices multiplied by 2 Rh choices. 4 doors in. But the same badges now travel outward on the donated A-positive cells. And other people's security does not see them the same way. The donated A-positive red cells approach a row of recipients. An A-positive patient recognizes them. An AB-positive patient can also accept them. But the other doors close. The A badge that helped identify the cell has become the reason more recipients reject it. 4 doors inward. Only 2 main doors outward. For a moment, A-positive looks far less useful than its commonness suggests. But then, the blood bag is placed into a machine and spun. The bag separates. Red cells settle into one layer. Plasma moves into another. And tiny fragments called platelets gather in their own layer. The apparent weakness belonged only to one part of the donation. The next part is about to make a comeback. Across the hospital, another patient is bleeding. This time, the problem is not simply missing red cells. The first patch over the damaged vessel will not hold. So platelets are called in. Think of them as an emergency repair crew. They race toward the crack, grab the damaged wall, and pile together into the first rough plug. Hospitals give platelets when a patient's own patch crew is too small or too weak during cancer treatment, after major bleeding, and in other emergencies. A-positive platelets are heavily used. In one reported year, the United Kingdom's blood service issued more A-positive platelets than any other type. They are not magically universal. Platelet matching has its own rules. But the donation that looked limited as red cells has returned as a frequently needed repair crew. Being common now becomes useful. Many ordinary donors can keep a heavily used supply moving. That explains why hospitals value A-positive today. But hospitals are new. The A badge is ancient. So the story leaves the blood bank and jumps thousands of years backward, to a wound with no doctor coming. An ancestor cuts a leg on stone. The vessel opens. Blood escapes. Platelets rush toward the break, but a repair crew cannot patch a wall if nothing holds the first worker in place. Then a protein called von Willebrand factor stretches across the damage. The name is difficult. The job is simple. It is repair tape. Platelets grab the tape. Another protein, factor 8, helps reinforce the patch. The leak begins to close. People with non-O blood, including type A, tend to carry higher average levels of this clot-supporting chemistry than people with type O. Across an entire population, that can mean more sticky material waiting when a vessel breaks. In a world of hunting cuts, animal bites, childbirth, and no emergency room, even a small improvement in early repair could leave more survivors. The wound closes. Our ancestor stands. The advantage appears to have worked. But the tape does not disappear from the story. It follows the blood into a vessel that was never damaged. Inside that healthy vessel, the useful patch begins forming in the wrong place. More platelets arrive. The repair grows. The road narrows. Then the flow stops. A clot can save a life when it seals a wound. The same clot can threaten a life when it blocks a healthy vein. Population studies repeatedly find this trade. Group O tends to carry lower levels of some clotting proteins and somewhat more bleeding. Non-O groups tend to experience more venous clots. That does not mean A-positive blood predicts your future. Think of it as a weather forecast for an enormous city, not a prophecy for one house. Age, health, medication, movement, pregnancy, and many other factors matter far more to one person. But across generations, the seesaw matters. In a world dominated by untreated injuries, extra repair tape may help. When unwanted clotting becomes the danger, the same tape becomes the cost. So evolution cannot simply choose more tape or less tape and finish the job. Before it can decide, a new attacker arrives, and this attacker is reaching directly for the blood group badge. A microbe approaches a cell like a thief testing door handles. Blood group sugar shapes do not appear only on red cells. Related shapes also appear on tissues and in body fluids, where microbes may use them as handles, disguises, or docking stations. Change the badge and one attacker can lose its grip. That looks like protection. But the next attacker may prefer the new door. Type O, for example, is associated with less severe falciparum malaria because infected red cells form weaker sticky clusters. O appears to win. Then the visitor changes. In some settings, type O has been linked with more severe cholera. Now A appears safer. Then the visitor changes again. Type A has shown worse illness with particular strains of toxin producing E. coli. Now, nobody wins. Every new attacker rearranges the doors. A shield against one visitor becomes a handle for another. So disease never pushes humanity toward one perfect badge. It keeps changing the exam. And because the exam keeps changing, evolution keeps more than one answer. The A badge enters a contest with O and B. One disease rewards O, another punishes it. One environment makes faster repair valuable. Another exposes the danger of unwanted clots. If one blood group were always superior, it should eventually crowd out the others. But it does not. Versions of the ABO system appear across other primates, and some of that diversity is older than our own species. Scientists call its long survival balancing selection. In plain language, evolution keeps several tools because tomorrow's job may not look like today's. The crown keeps moving. A survives. O survives. B survives. But surviving is not the same as becoming common. For A positive to appear again and again, two separate inherited instructions still have to meet. So the story enters a family. One parent passes down an A instruction. That can be enough to place the A badge on the child's red cells. Another inherited instruction helps produce the RHD badge. One working RHD instruction can often be enough for the child to be Rh positive. The two badges meet. A becomes A positive. Then the family moves. Migration carries those instructions into another population. Families mix. The combination appears again. Rh positive is widespread, and A is common in many large populations. So generation after generation keeps rebuilding the same two-badge cell. Changing diseases preserve multiple blood group strategies. Inheritance stores the instructions. Migration brings them together. But none of those forces knows what a blood bank is. Thousands of years later, the old combination returns to the emergency room where our story began. The recovered A-positive patient sits down to donate. The blood bag fills. The red cells travel through two main doors. The platelets travel toward patients whose patch crews are failing. Somewhere else, another A-positive patient can receive red cells through four doors. The ancient repair chemistry still carries both sides of its bargain, more average tape for a leak, but more opportunity for a roadblock. The badges still change which microbes find a handle and which lose their grip. Nothing about A-positive is perfect. That is why its real evolutionary advantage is not one superpower. It is the ability to remain useful as the problem changes. If A-positive is your blood type, it cannot predict your personality, your diet, or your destiny. But it does carry a record of incidents: wounds closing, roads blocking, microbes changing, families moving, and strangers keeping one another alive. The ambulance doors close. The next emergency begins, and the next blood type survives it by making a completely different bargain.